controlled trial will sort this out very quickly and would offer another therapy, particularly to the group of people cluster who've got some other comorbid problem with their heart, for example, and where the triptans make everybody nervous. This will, with any reasonable will, once one of these CGRP receptor antagonists become available, we'll be able to try to do this. The other thing that will happen, I just want to give you an impression of the pipeline of things that are happening that may impact your disease. The other thing that will happen is these things called ditans, those mitotans, the first one. They're the kind of next generation on from triptans. They interact with something called the 1F receptor. The detail doesn't matter so much, but these drugs don't. This is their effect on blood vessels down here. They don't have any effect on blood vessels, same sort of thing. There's a big push in pharma to develop medicines that don't have any cardiovascular, any heart or cerebrovascular, brain, blood vessel problem from a safety point of view. This works in phase 2 in migraine. We've got no reason to think it wouldn't work in cluster, but I know specific reason to think it would. There are, as I said, there are animal models that we can test it in, and if it makes sense, eventually something that might come again to your attention. It's like some years behind the CGRP receptor antagonist, but it just goes to show you there's a range of things happening that will happen over the next 5 to 7 years that will quite change the way the disorder is treated. And the other thing which is happening on the neurostimulations, I talked about deep brain stimulation, I talked about occipital nerve stimulation. Coming around the front is phenopalatine ganglion stimulation. So the nerve cells that mediate this watering eye and the blocked nose and so forth are in something called the pterygopalatine or sphenopalatine ganglion. These terms are equal in humans. Probably pterygopalatine is more correct, but sphenopalatine is used more often, most likely. There have been a couple of attempts to manipulate this structure over the years. This is some work from the Cleveland Clinic illustrating the possibility that stimulating this area would be useful. There's a controlled trial going on in Europe now. Some of the data was just reported at a meeting in Berlin by John Sherman, just the International Headache Congress a while ago. So I thought I'd show you what's going on. And this is not even the study's not finished. They're ongoing in the report. I think you see. So far, 12 patients with chronic cluster headache have been reported on. This is the stimulated device here. See this person? This is the finger. And that's the thumbnail there. So you see that the size of the actual, all the electronics is about the size of a thumbnail. Actually not a very big person's thumbnail either, not as big as mine. So when you compare that to, say, the kit for occipital nerve stimulation, you can see what's happening. But it's what you'd expect. Your phone that you have now is not as big as it was 20 years ago, because that's the way technology's headed. Nice little electrodes here. It gets put in up here. You go in the back, up the top of the jaw, and you can make a little incision and then place the thing in what's called the pterygopalatine ganglion without making any more holes or drilling anything about in particular. Fix it in with some little screws, and it seems totally bionic, doesn't it? And then you use this outside stimulator device in the lady's hand, and you hold it on here. When you get the attack, turn it on. So that would be an acute. What they're finding, this is the device, this is an X-ray of the device placed. What they've found is about half the patients who seem to be getting an effect, and this is the blinding hasn't finished yet, so they're doing active and non-active stimulation. Not only get a control of their attack, some people get that. There's a group of people for whom turning this thing on over a couple of weeks is turning their cluster off altogether. That's not something that's been so clearly observed with either deep brain stimulation or occipital nerve stimulation, because for both of them, when the batteries run out, the attacks tend to come back. For this thing, if it pans out to be true, it will be quite remarkable to be able to turn on the stimulator and have as recalcitrant as chronic cluster headache actually stop. And the mechanism behind this will be something interesting to pursue. So this is going on. This will eventually come to US clinical trials at some point, probably next year. I'm wanting to say. And this is even further on. So what I just showed you is actually happening today in Europe. This is further on the next sort of thing. There's a nerve called the vagus nerve in the neck. It does a lot of, it controls a lot of things in sort of visceral, some body cavity things. And you can access it, you can get into it, you can stimulate it. What this company, Neurocore's done is develop a stimulator, this device, which you hold on the outside. You can stimulate the vagus nerve from the outside. And they're looking at doing clinical trials in headache indications, again in probably 2012, to keep them off. So this doesn't require any sort of cutting or fixation or anything in particular. Whether it works on the whole other thing, but I guess, you know, I want to give you an impression that quite sensibly the device people are moving as much as they can from something as invasive as sticking an electrode in the brain, which is very invasive, back to these wires and so forth under the skin, which is less invasive. So there's a little device up here which is less invasive still. So not even poking anything anywhere, which is totally non-invasive, which you'll see what happens. It's very promising when you think about it like that. This is just a montage of these various types of these TAC syndromes, and the fact they all have this little area of the brain that's shared with the constant headache, and some of the anatomy that we understand. The detail doesn't matter so much. But to say that in a very short period of time, you've gone from having a really primitive understanding of an almost non-existent understanding of these conditions, to having some really reasonable understanding of what areas of the brain are involved, getting decent definition systems working, establishing how to do really high-quality clinical trials, where people, if you do them properly, they don't ask you whether something works. They just start to work out how to use it. It's really important that we don't have a lot of silly conversations about if, but a lot of conversations about how to implement knowledge. And all of this, of course, has been driven from the research side. I've said it before, and I'll say it happily again. It's been, for me so far in my career, it's been, I guess, one of the highlights, a privilege to work with people with cluster headache. I understand every time you get in the scanner and have an attack, that's not fun. It's not like you're sitting there having chocolate cake and coffee. It's an awful experience. And having an attack and knowing that there's a possibility you could be just taking a placebo during the attack, that's an awful experience. Doing all the things we're doing in research, they're awful experiences. And everyone on the research side really appreciates that we're willing to do those awful experiences just to make the world a better place for people with cluster in the future. Thank you for letting me be part of that, and thank you for inviting me here and happily taking your questions. Thanks very much. We want to take a little bit of time, I think, on the program.
One of your first slides you had up there talking about the headaches and the criteria. And it said on the headaches, 5 attacks. Does that mean that there was as little as 5 headaches or 5 episodes with headaches in them?
As little as 5 headaches.
So it could be just one cycle, one day that you had 5 headaches, or 1 week that you had 5 headaches.
Yeah, it could be by those criteria. You think I guess you think they're a little bit weak. I think the committee just sort of thought at the start the attack behaviour of cluster is so stereotypic that when you see when you see some of the attacks, that's pretty much what it is. That's the thinking behind it. What we say, if you had 5 attacks, for example, in one day and then you didn't have any more, the sort of official position would be that you could have cluster headache, periodicity undetermined, because we don't know whether you'll be episodic or chronic. That seems like a reasonable thing. There aren't that many things that behave with that that look like those attacks in medicine.